and Norton Children's Hospital. As a reminder to everyone, these are quick shots, so they're very quick. You have 2 minutes to talk, and you get 1 minute for one question.
All right, our first presentation is early cardiopulmonary resuscitation among infants with congenital diaphragmatic hernia, presented by Kylie Holden, a resident at the University of Texas, Houston.
All right. Slides. Okay, sorry guys. Hi, thank you so much for having me and having the opportunity to present our work. We have no financial disclosures. At birth, infants with congenital diaphragmatic hernia, or CDH, often present with hypoxemia, hypercarbia, and acidosis. While these conditions can become severe, they can quickly progress to cardiopulmonary failure, leading to life-threatening situations that may require CPR. And while it might seem obvious that these, Now, it might seem obvious that these patients obviously have poor outcomes. There's a surprising lack of data around these specific characteristics that describe these patient characteristics and lack of morbidity associated with these cases. That's why we set out to take a closer look at all these characteristics and outcomes of patients with who receive postnatal CPR. This is a retrospective study of the CDH study group between 2007 and 2022. We found out of approximately 7,000 patients, 987, or 13.8%, received CPR in the delivery room. These infants who received CPR had lower birth weights, worse 1-minute and 5-minute APGAR scores, had larger diaphragm defect sizes, and were more likely to have cardiac anomalies. However, in a multivariable analysis, searching for factors that were associated with their likelihood of receiving CPR, prenatal diagnosis of congenital diaphragmatic hernia, preterm delivery, urgent delivery, and low APGAR scars were more likely to be associated with this. They were also found to have significant morbidity. These infants had lower rates of diaphragm repair, increased use of ECLS, and higher rates of abnormal neuroimaging findings, and additionally, they were more likely to have surgical feeding access. They had overall lower survival rates, including lower birth weights, lower 5-minute APGAR scores, major cardiac anomalies, use of ECLS, and larger diaphragm defects were all associated with morbidity. So in conclusion, while all these patients had higher morbidity and mortality, there's a drastic need to focusing on targeted care, looking for opportunities for intervention, and provide thoughtful and proactive family counseling. Thank you. They don't have any. Okay. Any questions?
Are there any questions? Thank you. Our next presenter is Dr. April Carlson, and who will be presenting disparities in access to neonatal and pediatric ECMO services in the United States.
Thank you for the opportunity to present this afternoon. I have no disclosures. ECMO has revolutionized pediatric critical care and its ability to provide life-saving support for children, yet it requires highly specialized centers and expertise. Unfortunately, access to ECMO is not uniform, and significant disparities exist based on geography and socioeconomic status. Our objectives were to map ECMO centers relative to pediatric populations and examine regional differences to help better characterize disparities in access to ECMO across the United States. To do this, we used ArcGIS mapping and spatial analysis platform to identify densities of children aged 0 to 19 years and heat map them by zip code against different ECMO centers. We looked at their relative driving distances to identify coverage gaps for ECMO centers. Denser pediatric populations are labeled in darker blue, and the closer driving radii is in darker red. As you can see, the majority of ECMO centers are located in densely populated metropolitan regions, leaving large portions of rural America, particularly in the western US, without immediate ECMO access. We then examined the differences in demographic and socioeconomic factors for zip codes with driving distances less than or equal to 50 miles or greater than 50 miles away from the closest ECMO center. The Area of Deprivation Index, which is a marker that's used as a socioeconomic disadvantage scale, is one variable that I think well captures our conclusion of our data analysis, which is that ADI worsens with increasing distance from ECMO centers. Furthermore, we found that overall zip codes greater than 50 miles have a lower median income, a higher proportion of no education, a higher poverty rate, and higher unemployment rates, and are more likely to be rural. Thus, our study suggests that socioeconomic disadvantage influences access to ECMO long before a patient arrives at an ECMO center. While ECMO care may be delivered equitably once the patient has arrived at the center, there are systemic barriers such as geographic isolation, poverty, and healthcare infrastructure that may prevent populations from accessing ECMO in the first place. Thank you.
Any questions?
Thank you.
Thank you.
All right. Our next presentation is Early and Often Healthcare Utilization in Children with Surgically Treatable Congenital Anomalies, presented by Danielle Ellis. Sorry, resident in general cardiothoracic surgery at Mass Gen.
Good afternoon. I'll be presenting this information on behalf of our group. We have no disclosures. Surgically treatable congenital anomalies have a pretty substantial burden of healthcare utilization, owing primarily from a patient standpoint to symptom burden, psychosocial difficulties, and in particular, early surgical intervention that often requires intensive decision-making. We took a look at 5 different surgically treatable congenital anomalies based on both incidence and severity, and through a retrospective review of the Medicaid market scan database between 2016 and 2020, looked at children who were enrolled from birth to 2 years of age with the following 5 conditions: congenital diaphragmatic hernia, tracheoesophageal fistula and esophageal atresia, gastroschisis, biliary atresia, and intestinal atresias. And what we ultimately found when we looked at both inpatient stays, outpatient encounters, including visits, emergency department visits, and surgical interventions, all to sum their healthcare days, were that there was very significant healthcare utilization over those first 2 years. What you can see on the x-axis is the age broken up by months between birth and 2 years of age, and on the y-axis, the median number of healthcare encounters, again, that are summed to include all of those. This is highest utilization for patients with gastroschisis, and there's a clear trend where there's really substantial utilization in those first few months of life that increases again once you get into the second year of life, but shifts primarily from the inpatient to the outpatient setting. In terms of surgical interventions, we found that the median overall for these conditions was 6 over those first 2 years, and was ranged between 5 and 7 for each of those conditions, and was more in the TEF, gastroschisis, and intestinal atresias group. We, as an aside, took a look at palliative care consultation for each of these patients, which was very infrequent, less than 2% for most patients, and only 4% for diaphragmatic hernias, mainly because this burden of surgical decision-making is clearly something to intervene upon and might be a touch point for patients when they need support for these many encounters over the course of those first years of life. Thank you.
Any questions?
Are surgical interventions listed related to the index anomaly, or is that all surgical interventions?
It was all surgical interventions, but each patient only was included based on only having one of those conditions. So presumably any additional comorbidities that may have been intervened upon were sort of sequela of the initial disease as opposed to something entirely separate.
Thank you.
Thank you. Our next talk will be Social Inequities in Pediatric ECMO Outcomes, the Role of the Child Opportunity Index, presented by Dr. Christopher Neme at Columbia University.
All right, so I'm Christopher Neme, Pediatric ECMO Fellow at Columbia, and joining as a PGY4 resident this June in general surgery. We have no disclosures, So pediatric ECMO is resource intensive. There's disparate access to different patient populations. Lower resource children on ECMO may be susceptible to differences in the timing of presentation, differential hospital treatment, and different access to follow-up care, which may affect outcomes. So we looked at the Child Opportunity Index, which is a comprehensive measure of neighborhood resources and conditions that affect healthy child development. And we categorized it into quintiles, which are low, very low, moderate, high, and very high. And we looked at 1-year outcomes, survival and morbidities, and then ECMO populations most likely to be affected. So we divided the cohorts into cardiac, ECPR, and respiratory, as shown here. There was no difference in weight, race, or ethnicity. And if you look at the COI quintiles, most of them were either very low or very high, and then scattered throughout low, moderate, and high. And the overall 1-year survival was around 54%. And there was no difference in ECMO hours or length of stay based on the COI. So very low COI patients had lower survival per our Kaplan-Meier analysis, and this was a statistically significant finding with a hazard ratio of 0.719. And here we stratified very low COI versus all the other groups, and they had significantly lower survival at discharge and 1 year. We also looked at cardiac patients versus respiratory and ECPR. The reason respiratory and ECPR aren't here is because they were not significant, but cardiac patients had a higher odds ratio of having a G-tube or living in a long-term care facility. And this was a stratified multivariable model for race, gender, race, ethnicity, weight, and comorbidities. So in conclusion, very low COI is associated with decreased survival. Cardiac patients with very low COI have particularly discrepant outcomes, such as higher odds ratio of having a G-tube or living in a long-term care facility. And short and long-term ECMO outcomes are influenced by social determinants of health, so there's ongoing need to address drivers of inequitable care. Thank you today. Any questions? All right, thank you.
Thank you. All right, our next presentation is perioperative factors associated with surgical site infection following laparotomy in neonates, presented by Catherine Yip, general surgery resident at Mount Sinai Hospital.
Good afternoon, everybody, and thank you so much for APSA for the opportunity to present my work here today. This is a study of perioperative factors associated with surgical site infection following laparotomy in neonates. I have no disclosures. Surgical site infections are one of the most common causes of postoperative morbidity. These are known to increase hospital length of stay, increase medical costs, and prolong postoperative recovery. Neonates are particularly vulnerable as they have immature immune systems, face frequent antibiotic usage, and often have prolonged hospitalizations. As such, this project sought to identify modifiable risk factors associated with SSIs. This was a single-center retrospective review of all patients in a level 4 NICU at an urban tertiary care center who underwent laparotomy between 2013 and 2021. We performed an analysis of pre, intra, and post-operative factors associated with the development of SSIs. 212 patients met inclusion criteria, 63 of whom had surgical site infections. On univariate analysis of patient characteristics, we found that SSIs were significantly associated with a younger gestational age. On analysis of intra- and postoperative factors, SSIs were found to be significantly associated with class 4 surgical wounds, longer procedure duration, intraoperative blood transfusion, and use of non-occlusive dressings. On multivariate analysis, younger gestational age and longer procedure duration were found to be significantly associated with surgical site infection. In conclusion, risk-adjusted analysis demonstrated that younger gestational age and longer procedure duration were associated with SSI development. There were multiple factors found to be significant on univariate, but not on multivariate analysis. Future directions include continuing to enroll more patients in this analysis as we look through more variables that may affect our rate of surgical site infections. Thank you to everyone, including my mentor, Dr. Coakley, and I'm happy to take any questions or comments at this time.
The question you haven't asked, or at least told us, were these cases all done in an OR, or did you do them in the ICU?
These were all done in an OR.
It's an important consideration.
Yes. Thank you.
you.
Thank you.
Thank you.
Our next talk will be presented by Dr. Daniel Leisman. It's PRIMO, a novel multi-parameter probe for premature infant monitoring during surgery. He's a research fellow at Lurie Children's Hospital.
All right, good afternoon. I'm pleased to present our work on a premature infant monitoring probe. We have no disclosures. Premature infant monitoring devices are inconsistent as they rely on peripheral perfusion, and the most accurate devices are invasive. Ultimately, accuracy is vital for safe surgery. We therefore designed a singular probe for vital sign assessment via central perfusion through placement in the rectum of the esophagus. The probe, entitled PRIMO, can track heart rate, pulse oximetry, temperature, and potentially respiratory rate. To validate PRIMO's ability to monitor heart rate and blood oxygen saturation, it was inserted into the rectum and the esophagus of a premature lamb on placental support. The lamb was then intubated, an umbilical artery catheter placed, and a reference pulse oximeter attached for monitoring. The cord was then severed and vent turned off to induce physiologic derangement. Our gold standard for heart rate was an echo, and blood oxygen saturation an ABG. Here's a representative heart rate from one of the experiments showing that it mirrors the echo results closely throughout periods of bradycardia and tachycardia. Additionally, its SpO2 readings track the significant hypoxia identified on ABGs throughout episodes of breath holding. To assess PRIMO's true accuracy, we compared the heart rates and saturation data from all experiments on Bland-Altman plots. Both the heart rate and SpO2 show minimal bias from PRIMO in comparison to the gold standards. Lastly, we compared PRIMO to a reference pulse oximeter. Here, the red bars indicate incorrect readings from the devices. On the left, you can see that both devices recorded accurate heart rates throughout periods of bradycardia. However, more importantly, during periods of severe hypoxia, PRIMO maintained accurate readings a greater percentage of the time. In conclusion, we believe this device will help bolster the accuracy of neonatal monitoring while minimizing the number of different systems required for accurate vital sign assessment. Thank you.
Are there any proposed size restrictions for this type of catheter? Can it be used in fairly small premature infants? And the second question is there any kind of interference associated with a patient that isn't fully sedated?
First is a great question. This probe was actually initially developed to monitor for in utero fetoscopic surgery. So we validated it for FMMC repairs on lambs, and it works quite well, actually showing that there is significant hypoxia before the onset of bradycardia. So with that in mind, we wanted to move on to see if it actually worked in the premature population. And then second, we have only tested this on premature lambs that are sedated, not paralyzed. So it's unclear as of right now if a lamb was fully awake and moving around how accurate it would be, but that would be a good next step.
Thank you. All right, our next presentation is Evolving Utilization of Inhaled Nitric Oxide in Congenital Diaphragmatic Hernia Over Time, a national cohort study of 4,016 infants, presented by Anne, excuse me if I mispronounce this, Seskleifer, resident physician at Johns Hopkins.
Thank you. Inhaled nitric oxide, or INO, is a costly pulmonary vasodilator with unclear benefits in infants who have congenital diaphragmatic hernia. While it's been shown to improve oxygenation and reduce the need for ECMO in other populations, to date, the literature in CDH does not support its use. Since these initial studies, we aim to define the current utilization trends and evaluate contemporary outcomes. We used the FIS database, identified just over 4,000 patients from 47 institutions, and stratified into high and low use centers. Our primary outcome was in-hospital mortality, and our secondary outcomes were complications and cost. We found that INO use decreased from 51% to 43% use over the study period, and in the graph on the right, you can see the variability in INO use by hospital. The Q1 high-use hospitals are shown on the left, and then the fourth quartile low-use hospitals are shown on the right. In our analysis, any patient treated at one of those institutions, regardless of whether or not they received INO individually, were included in that cohort. There was similar baseline demographics between the groups. Of the 615 patients treated at low-use centers, around 30% received INO, and of the 695 patients treated at high-use hospitals, around 70% received INO. There were slightly lower APGAR scores in the low-use INO groups compared to the high-use hospitals. We found high-use INO centers are associated with significantly higher mortality. As you can see in the graph on the left, the percentage use of INO at each hospital is shown in the black dots, and the percent mortality is shown in the orange triangles. This is for all 47 FIS centers. You can see our stratified results on the right in this Kaplan-Meier survival curve, where the low-use INO centers had survival rates of 87% compared to 80% in the high-use centers. High-use centers also had no difference in ECMO rates or duration and were correlated with higher morbidities, including longer ventilator days and higher rates of thrombosis, stroke, and seizure. They also had higher resource utilization in terms of both length of stay in the hospital and hospital charges. In conclusion, we found heterogeneity in INO use across centers. We also found that high-use centers were associated with an increase in mortality and morbidity and resource utilization. Thank you.
This is great work from Dr. Kunisani's team, I think one of the questions on my mind is, do you have any data about center volume? Because I think that there are good data that in CDH, centers that take care of a lot of patients, so high volume CDH centers, not high users of INO, may have better outcomes or different practice patterns. Do you have any information of that from FIS?
We did look at that as well. We did not find a correlation. We had run some additional analysis. I don't think it's on this slide. This is just looking at INO use. But to answer your question, no, there's no
Thanks a bunch.
difference. Thanks.
Our next talk is outcomes following implementation of a risk-based treatment algorithm for infants with necrotizing enterocolitis and congenital heart disease, presented by Jordan Rook, resident at the Department of Surgery at UCLA.
Thank you. Infants with congenital heart disease are at increased risk for intestinal ischemia. These cases, which typically develop due to splanchnic hypoperfusion, differ in pathophysiology from traditional neck of prematurity. Despite this, these infants are often treated aggressively with pathways defined for traditional neck. Given this discordance, we implemented a treatment algorithm in May of 2023 that utilized 11 clinical factors to guide treatment for infants with CHD and intestinal ischemia. To assess this algorithm, we conducted a retrospective cohort study including infants with congenital heart disease and intestinal ischemia treated at our institution from 2021 to 2025. We compared infants treated pre versus post algorithm implementation. We assessed the outcomes of NPO and antibiotic days as well as abdominal x-rays. We also assessed balancing measures, which are unintended consequences of QI efforts. We assessed outcomes with bivariate analyses and changes in variance with run charts and variance ratio testing. We identified 51 patients, 22 of whom were managed post-algorithm implementation. Algorithm implementation was associated with a significant decrease in the number of abdominal radiographs and decreases in NPO and antibiotic days, although this did not reach statistical significance. There were no changes in the balancing measures of need for surgery, recurrence, or death due to intestinal ischemia. There was, however, a statistically significant reduction in the variance in all outcomes following implementation. This can best be seen on run charts, which show changes in outcomes over time. For example, on the left, you see a marked reduction in variability in antibiotic duration following implementation, shown by the vertical dashed line. The same reduction in variance can be seen on the run chart on the right, depicting the number of abdominal radiographs. In summary, a treatment algorithm specific to infants with congenital heart disease and intestinal ischemia can safely reduce treatment intensity. As for next steps, we plan to expand this to other centers while seeking to iteratively streamline and improve the effectiveness of this algorithm. Thank you. If you would like to view the full algorithm, please use the QR code. I'll take any questions now. Thank you.
Our next presentation is multicenter external validation of methods to identify surgical necrotizing enterocolitis, presented by George Bethel, NIHR doctoral fellow and pediatric surgery registrar at the University of Southampton.
Thank you for the introduction, and thank you for the opportunity to present our work here today. So the decision to operate or continue medical management in NEC is often challenging, and recent data suggests that these challenges can lead to delays in undertaking surgery, which overall are linked to poor outcomes in these babies. Decision-making is often subjective. However, we've undertaken a recent systematic review, and we identified 63 unique objective methods available to using clinical, radiological, and laboratory data to define a threshold for surgery in these babies. It's unclear, however, how these compare to each other and whether any are actually suitable for clinical practice. So we've undertaken a multi-center external validation of these tools, and we defined the cases as surgical NEC, which was surgery for NEC or death without an operation, and all other confirmed cases of NEC were the controls. And we were interested in measures of tool effectiveness. We observed just under 220 infants, of which 142 were defined as surgical NEC, and we were able to externally validate 36 of these tools as they use readily available data. This table shows the best 8 performing tools as ordered by sensitivity. The most effective test was platelet to lymphocyte ratio, and overall measures of test effectiveness was between 55 and 70%. And this was the true positives and true negatives out of the whole cohort of infants. So some of these tools may be useful in clinical practice, and particularly those with a high sensitivity could have a role as an early warning system for surgeons, saying that a clinical review is indicated. However, further refinement of the best performing tools is required, and we look to include more infants in this data set from more centres, and we're also looking at combining the best performing tools to see if we can increase these measures of diagnostic accuracy. And overall, our aim is to increase the objectivity of decision-making in babies with NEC. Thank you for listening, and I'd welcome any questions.
Did you use any of these tools yourself?
Yes, so all these tools were applied retrospectively to this data set.
No, I mean in clinical practice.
No, yes, we're not actually using any of these in clinical practice yet. I think that's the next step of the work, to look at how we can combine some of these best performing tools to see if we can increase these overall measures of diagnostic accuracy, because really we need something that clinicians are going to buy into, and I think that's a challenge of presenting something with low measures of diagnostic accuracy.
Thank you.
Hi, NCA Campbell from UPMC. From your list of the different diagnostic tools, do you think any of them are able to diagnose NEC earlier than others?
So we specifically looked at the decision-making for surgery or not. There's a whole other part of the literature out there devoted to early diagnosis of NEC. I know it's all quite closely linked, but we specifically looked at the question of early recognition of babies that should undergo surgery for NEC.
Right, thank you.
Thank you.
Our next talk will be Elevated Healthcare Utilization and Mortality in Mothers of Children with Congenital Surgical Anomalies, a 50-year population-based case control study, presented by Dr. Marietta Jank, resident in pediatric surgery at University Medical Center in Mannheim.
Hello, thank you very much for the opportunity to present some of the results from a project that I conducted during my research fellowship with Dr. Kaiser at the University of Manitoba. We have no conflicts of interest to disclose. With advances of medical and surgical care, most children born with congenital surgical anomalies now survive well into adulthood. So the focus is more from the mortality is shifting more to the morbidity, resulting in often intensive long-term caregiving demands. The complexity of this ongoing care often poses significant challenges, not only on the child or the patient itself, but also on the family unit. So therefore, we investigated what effects does the healthcare utilization of the survival have on mothers with children from congenital surgical anomalies versus mothers from healthy controls. In order to tackle this question, we use a unique database link. So we have an individual level data set on congenital surgical anomalies, which we linked with a population-based data repository on a provincial level, which has two benefits. So one is that you can link for every one child with a congenital surgical anomaly 10 healthy controls born on the same day. So you have the same kind of risk profile and health care that they are exposed to. And the other benefit is that you can actually link it to their family. So we focused in our project on the maternal outcomes. And we could see that mothers of children with congenital surgical anomalies have a decreased survival compared to mothers of healthy children. And there were particularly pronounced difference in mothers of gastroschisis and esophageal atresia patients. When looking closer at the findings with regards to the healthcare utilization, we could see that mothers of children with congenital surgical anomalies had an increased healthcare utilization, both in regards to ambulatory visits as well as hospitalization. And when we looked at this in a Poisson model, looking at frequency factors that significantly influence this healthcare utilization, with socioeconomic factor, the number of children in the family, and urban residency. So to conclude, we show data that the long-term follow-up, the long-term care should not only be focused on the child, but should also take the family into account. And we actually show data which supports that there's health impacts on the mother. Thank you very much for listening, and I'm open for questions.
Do you have any data on the cause of death in these mothers? I'm interested in the socioeconomic factors, particularly related to gastroschisis, and wonder if understanding the cause of death is key to understanding what we might do about it.
Thank you for that question, and it's a very important one. We actually don't have data itself about that, but we are looking into that. There's data from Denmark, because it's always tricky with these studies that you need population-based data. So Denmark is one of the countries that also provide that data very well, and they have shown that it's mainly cardiovascular risks that are related to an increased mortality. What's very challenging is when you do these kind of studies is what you control for. So with regards to gastroschisis, the age of the mother, is she taking any drugs? What's the socioeconomic factor? It's a very challenging field to take everything into account because there's just certain factors you can control for. So what's so nice is to have the matched controls that are born on the same day and therefore exposed to a similar environmental factor. Thank you.
Thank you.
All right, our last presentation for this session is identifying risk factors explaining a rise in gastric perforation in the NICU, the first step of a quality improvement initiative presented by Lily Puterman-Salzman, a medical student at the University of Montreal, Division of Pediatric Surgery.
Thank you for the introduction. I have no conflicts of interest to disclose. Gastric perforation in neonates is a rare but serious complication that is associated with high morbidity and high mortality. Understanding contributing factors can lead to earlier identification, prevention, and better management strategies. After observing an unexpected increase of cases at our institution, the largest mother-infant pediatric hospital in Canada and a major referral center, our team aimed to identify potential risk factors that could help with prevention guiding. To achieve our objective, we conducted a retrospective chart review on patients diagnosed with gastric perforation between 2014 and 2024. We identified 21 cases in total. Interestingly, there was a statistically significant increase in cases after 2018. This rise coincides with changes made at our institution that same year to nasogastric tube practices, and specifically to the frequency of NG tube insertion and changes of material to polyurethane. We then compared patient data and common risk factors from before and after 2018, which correspond to the pre- and polyurethane eras on the table. While commonly reported risk factors were assessed, the only clear trend that emerged was an increase in the number of NG tube exchanges before perforation, as can be seen here. Based on these findings, our team is now reviewing current nasogastric tube insertion protocols with our hospital's nursing teams, and we are expanding the investigation to other areas to include feeding and ventilation practices. Our final goal is to implement targeted interventions which ultimately improve patient safety and reduce risks of perforations in the future. Thank you very much for your attention, and are there any questions? Nope, thank you very much.
All right, thank you, everybody. That was the end of the session. Please find the speakers if you have any additional questions for them. And then next we have our first set of breakout sessions and 2 workshops.
Okay.